Thank you, Gemma, for your nice introduction. I'll start sharing my screen now. Well, good evening, everyone, or maybe good afternoon for some still. It's a pleasure to be here for you together with my colleague and friend Channing Rout from Boston to discuss with you multidisciplinary approaches for treating GISTs. We try to cover all aspects of treating GISTs in any way, although we only have an hour, so we have to be comprehensive, but still. We hope to do it in an interactive manner for you. So we will have some cases, we will have a poll. So I hope in the end you feel you had an entertaining night in an era when all theaters and other entertainment is closed. So consider this night entertainment for all of you. So we have no disclosures, both of us. Let's start with an introduction. GIST tumors or gastrointestinal stromal tumors are rare tumors. 50 per 1 million is the incidence, and although they're always found in the GI tract, we still consider them soft tissue sarcoma based on their cells of origin. These cells of origin are the cells of Cajal, which you consider as mesenchymal cells that are located in the submucosa of the bowel or the gastric tract. Usually these GISTs are found in, as coincidental findings when people have CT scans for any reason, or sometimes people can have symptoms including bleeding, melena, or a general not well-being, or just fake abdominal pain. The size of the GIST can vary widely from very small tumors that are found accidentally to very large tumors where people will have symptoms. Here are some examples of different sizes. On the left upper corner, you can see a very small GIST that was found accidentally with a small bowel resection for a different indication. And then you can see some sort of intermediate size. And then the last one is a large GIST that we recently operated. When it comes to locations, GISTs are most well known from the gastric locations, and yes, this is the most frequently seen location of a GIST tumor. 55% of all GISTs are in the stomach. However, there are definitely other locations where GIST can occur, mostly in the small intestine, either duodenum or jejunum, but also in the rectum and sometimes in the colon, and very rarely in the esophagus we can see GISTs as well. Very important, especially when it comes to locally advanced or metastatic GISTs, is the mutation type of the GISTs. The most frequently mutation found in these tumors are c-KIT mutations. As you can see on the right side in blue, around 63% of all GISTs are actually KIT mutations. And then another important group is the PDGF receptor mutations, 11% in yellowish. And then there is a whole list of other mutation types that are seen in GISTs, including NF1, sometimes seen in neurofibromatosis patients. Also BRAF, known from the melanoma field, obviously, and also quite often hereditary SDH deficient GISTs. On the left side, there is a picture of the KIT and the PDGF receptor that are membrane bound, and you can see the different exons where you can find mutations. Most frequently found mutation is the exon 11 in the c-KIT, and we will come back to that later on. So, since this is a surgical oncology society, and since I think most of our attendees are surgeons, let's just state the obvious, which we all know as surgeons, but still, surgery is the principal treatment and the only curative treatment option for localized resectable primary GISTs. And even new tyrosine kinase inhibitors didn't change that, not even imatinib. So what about GISTs? So I mentioned before, they can be small or large, and they can progress and even metastasize. So usually it starts with a small nodule that are often found. Sometimes they are found as localized small lesions of maybe 2 or 3 centimeters, sometimes already 5 or 6. And sometimes these large tumors that are still localized can present as very large masses intra-abdominally. When we move on, then we can see metastatic disease, mostly in the liver and intra-abdominally. And for these patients, usually, well, we don't use surgery up front anymore, and we think about imatinib or even second or third line systemic options. We'll come back to that slide later. So this is the ESMO guideline that some of you might be familiar with, which came out in 2018, but in a few months, a new version will come out with an update of all treatment and diagnostic advices. And most of the, let's say, 6-7 next slides are based on these guidelines. So first of all, what about the workup of these tumors? Well, at least these patients, especially when it's in the stomach, obviously need a gastroscopy. And when this is performed, it is preferred to do an endoscopic biopsy when possible to make the diagnosis. If for some reason an endoscopic biopsy is not feasible, for example, for jejunal cysts that are large or for whatever other reason are not accessible endoscopically, transcutaneous biopsies are needed. We still prefer to do a biopsy to know the diagnosis and also to distinguish from other tumors that might need other treatment. For example, if it's a lymphoma or a colon cancer or a small bowel cancer, we definitely need other treatment than a GIST, and that's why we always say we prefer to do a biopsy beforehand. Although in the past it has been suggested that this is actually not safe and that this encourages or even stimulates metastatic disease. We published a paper 2 years ago that is in fact safe, and biopsying GIST does not lead to more spreading or a worse outcome. In terms of imaging, and CT abdomen pelvis is the standard of care, and sometimes CT chests are performed, although this is still something that we can debate about since GIST hardly metastasizes to the chest. PET-CT is sometimes performed as well in some centers. In general, thinking about surgical principles in operating GISTs, well, the first rule that is basically a rule for every type of cancer is that we want to resect the tumor with clear margins. However, the margins don't need to be very extensive, like 2 centimeters or 3 centimeters that sometimes is suggested. Even 1 millimeter is enough of a margin for GISTs. Lymph nodes are almost never involved in GISTs, so lymph node dissections or lymph node sampling is not indicated. But what makes GISTs different than many other types of cancer is that they can be really fragile, that they easily rupture, and ruptured GISTs have a dismal prognosis and most likely need lifelong imatinib. So this is something we really want to prevent. So that is also something we need to consider when we do minimally invasive operations for GISTs. In general, which is also in the guidelines, it is stated that for smaller tumors that are operated upfront, laparoscopic or even robotic resections are definitely safe and usually performed, which we do as well. But if we have very large tumors, we discourage laparoscopic surgery, given the risk of rupture, and even more, we really prefer neoadjuvant treatment for these cases, and we will come back to that as well. So, what is the surgical strategy for these tumors? In general, just to make it clear, small GISTs smaller than 2 centimeters do not need any treatment or resection. When GISTs are a bit larger, primary resection is indicated, like the example that I put on the right side, on the upper right side, which is a relatively small GIST of about 3 or 4 centimeters, and this is definitely a GIST that you could operate laparoscopically upfront without any other treatment. However, when GISTs are large, like the lower right corner, this is definitely a GIST that we would consider neoadjuvant treatment in, and we wouldn't operate on this GIST upfront. And then in general, when downsizing of a GIST might lead to organ preservation or function sparing resections, we really encourage neoadjuvant treatment. Just a little bit more about the small GISTs, smaller than 2 centimeters. In the past, they were considered to be benign, and this, although in the HWA classification it is not mentioned as a benign tumor anymore, it is still a GIST that has a very small risk. So in general, when GISTs are diagnosed as small tumors, either with endoscopy, as you can see on the left lower corner, or the example that I showed before, intraoperatively, these these GISTs do not need any follow-up if they have been resected, and if it has been found and it has not been treated, we usually limit the follow-up to maybe a year or maximum 2, just to see that it's not growing, since every large GIST usually also starts with a small GIST, so that's something we just want to observe. When we find a small nodule, for example, in the stomach, smaller than 2 centimeters, and we don't have any diagnosis, we still advise to do observation, for example, after 3 months with a gastroscopy or maybe even a CT scan, and then do 1 more scan a year later. And if it's still stable, you can discharge the patient. What about surveillance? It's a question we frequently get from patients, or and also from physicians or surgeons outside of centers of excellence. We generally say that for low-risk patients, we follow them for 5 years with 6 to 12 monthly CT abdomens, which is also in the guidelines. While for high-risk patients, we follow them for 10 years, but the frequency of the CT abdomen goes down, obviously, when time goes on. Jen, you will come back to cases later in questions.
All right, so we're going to switch. I'll do the screen share now. All right. So you've heard from Dr. Van Hout that the management of GISTs in general and for small GIST. But now as we get into the more clinically relevant size GIST, the GIST that we worry about that are going to spread, we want to consider all of our treatment options. This study from Memorial Sloan Kettering, which looked at a total of 200 patients, 80 of whom had primary GIST, had a very striking finding. And amongst those 80 patients that underwent a hypothetically curative resection for a primary GIST, the 5-year overall survival was only 54%. And this raises concern about the potential for this tumor to recur even after a hypothetically curative resection. At this point, imatinib was being investigated as a treatment for metastatic disease or advanced disease. And so trials were designed to look at it in the adjuvant setting. Part of that was also based on risk stratification. This study by Miettinen and Lasota out of the Armed Forces Institute of Pathology in the US stratified patients based on 3 key prognostic factors, which seem to be independently predictive of outcome: tumor size, tumor mitotic count, and site of origin. And so the color coordination here, the dark green is very low risk, the light green is low risk, yellow is intermediate risk, and red is high risk. And as you can see, for any particular size, a GIST arising in the stomach has a better prognosis than a comparably sized GIST with the same mitotic count arising in the small intestine or colon. So let's see, where's the slide advancing? There we go. So with the advent of imatinib, the use of imatinib in the adjuvant setting was considered. Now, this is a Time magazine cover which highlighted the efficacy of this drug as one of the vanguard of targeted therapies. And it was, in fact, I think, Drug of the Year in 2001 by Time magazine. So the first of the adjuvant studies that was launched was the ACOSOG Z9001, launched in the United States. In this study, this was a 1-year randomized trial looking at 1 year of adjuvant imatinib compared to placebo for patients who had a primary KIT-positive GIST that was at least 3 centimeters in size and had undergone a macroscopically complete resection. 713 patients were enrolled, and the primary endpoint was recurrence-free survival. As you can see, the patients in the imatinib arm, shown in the light blue on top, had a recurrence-free survival of 98% at 1 year, compared to 83% for the placebo arm. And this led to the approval of imatinib as an adjuvant therapy. The overall survival was no different between the 2 arms, but there was a crossover design built into the study, so this is not particularly surprising. The second key study that was published was the SSG 18AIO Scandinavian and German adjuvant study, which compared 3 years of adjuvant imatinib to 1 year of adjuvant imatinib. The patients that were enrolled included some patients that were much higher risk than in the ESSO trial that included these risk characteristics. Patients were randomized to one of these two treatment arms. Almost 400 patients were enrolled. As seen in the ESSO study, this study found that there was an improvement in recurrence-free survival with a longer duration of therapy. But what was really striking about this study is that there was also an improvement in overall survival with longer duration. And so this has now set the standard of use of adjuvant imatinib for at least 3 years for patients with appropriate risk. And we'll get into the risk issue in a minute. The long-term follow-up of this study was published last year, and that shows that there's a sustained benefit both in terms of recurrence-free and overall survival with the longer duration of therapy. There was another analysis that looked at the outcomes based on specific imatinib mutation, and the benefit for the adjuvant imatinib therapy was basically seen in a subset of patients who had KIT exon 11 deletion or insertion deletion mutations. Those that had KIT exon 9, other KIT exon 11, or wild type mutations did not seem to have any benefit with the use of adjuvant therapy, at least at the dose that was administered for this study. A third key study was the EOR. Looks like there's an EORTC study that also looked at an interesting survival endpoint, which was imatinib failure-free survival. And ultimately, it appears that there is a benefit towards a certain group of subset of patients with the longer duration of therapy that compared 2 years to 0. This was a 5-year single-arm study that was done in 22 institutions in the United States that basically looked at 5 years of adjuvant therapy to see if there was any benefit to longer-term therapy. This was initially planned as a randomized trial, but we did not secure the funding to do it as a randomized study. The patients that were at risk or were enrolled had these tumor characteristics, and patients were all treated with 5 years of adjuvant therapy. The recurrence-free survival here was 90%, and the overall survival was 95%. What was an interesting outcome from this study was that nearly half the patients did not complete 5 years of adjuvant therapy, and that suggests that even knowing the good outcomes that were seen already at that time from the Scandinavian study, that it was challenging to keep patients on a long-term adjuvant trial. There are 2 trials that are currently underway. A 3 versus 6 year randomized discontinuation study for adjuvant imatinib with an estimated date of completion in December 2022. This is out of the French sarcoma group. And then there's another Scandinavian sarcoma group randomized trial of 3 versus 5 years of adjuvant imatinib with the estimated completion date of May 2028. So the take-home points from this discussion about adjuvant therapy and treatment of small GIST is that surgery remains the primary treatment for GIST that are localized, although those that are under 2 centimeters in size could potentially be observed. The trial data support the use of adjuvant imatinib for at least 3 years in patients with resected primary GIST that are at least at high risk and potentially at intermediate risk of recurrence. Specifically, KIT exon 11 deletion in their insertion deletion mutation patients are the ones who seem to benefit the most from adjuvant therapy. And again, here, that means that patients that are falling into these red risk categories. There is some difference across the Atlantic in terms of how it's approved for adjuvant use. In Europe, it's more strictly limited to patients with high risk of recurrence, whereas in the United States, patients with intermediate risk can be treated, and that requires careful counseling between patient and doctor. All right, I guess we now turn it over to you.
Yeah, let's start with a question, because I see a question from Terry. Maybe I will ask that question to you, Jen. So if smaller GISTs are recommended for primary resection and large for neoadjuvant treatment, what is the size distinction between smaller and larger? What are the criteria?
Right, I think that this is an excellent question. I think this is one that comes up in the clinic all the time. And my approach, and I'm interested to hear what you think, Wynn, about this, is that if I can do this laparoscopically up front, and the scope of the operation is not going to take too much of tissue, for instance, requiring, say, a Whipple procedure for a duodenal gist, then I'll just treat them up front with surgery. But if I feel like it's going to potentially be require more organ resection or require an open procedure up front, then I'll use neoadjuvant therapy.
Yeah, I agree. I as you know, I have some slides about that later. Also, an answer to Terry to go into that a little bit more detail. And I think I put it there on purpose this way, because we can't easily say if it's a 10 centimeter GS, do neoadjuvant, or if it's 6 or 5 or 7, just do it up front. It really depends on some other factors that I will go into. But in general, if it's going to be a morbid procedure, if we feel you need to do, to take a multi-organ resection or to do a large open resection, if you downsize the tumor, that might lead to a smaller resection, or even a laparoscopic procedure, then we tend to do it. So it's not black and white. This is the size where you need to do it this way, and this is the size where you need to do it that way. And that's exactly why we feel that larger GISTs should go to centers of reference that have a lot of expertise with GISTs, because it's always a difficult debate which patients need neoadjuvant treatment and which patients do not.
It can vary from organ to organ, right? 5 centimeter in the stomach is different than, say, a 5 centimeter in the esophagus or rectum.
Yes, so agreed. So let's go to this first case. And I think we need to poll as well a question. So this is as you can see, this is a relatively small primary GIST. It is, let's say, 4 centimeters. So what would you do in terms of diagnosis? Would you take this out up front? Would you try to take a biopsy endoscopically, or would anyone go for a transcutaneous biopsy? And I think, Gemma, that the poll is coming up now.
Yeah, no problem. I'll launch it now.
In the meantime, when everyone picks an answer, there's another question. What is the response for neoadjuvant imatinib? And we will get back to that answer later.
So far we have 70% of the participants who have voted, so I'll just give them a couple more seconds before ending and sharing.
Yes. 3 options.
Okay. Right, I'm going to end the poll now, and I'm now sharing the results.
So no one would do this transcutaneously. Well, the majority would say, let's do an endoscopic biopsy, which I think Chen and I would do as well. But there's still 20% that feel that just go to surgery. Any comments on this, Chen?
Right. I think that this is, reflects what we typically see in the community, probably around the world. There's no right answer. I think that there's probably a little bit more of a bias towards an endoscopic or biopsy or an endoscopic fine needle aspiration amongst patients, amongst physicians who treat a lot of sarcomas, since we tend to do biopsies a lot. So I think that that tends to be more of a bias we'd see, especially in sarcoma centers.
Yeah. So you could also say, so what if you don't do a biopsy and you just, because even if it's a GIST, you don't want to treat them neoadjuvantly. So that for that reason, there's no need to do a biopsy. But there are some other diagnosis possible if you see a lesion like this, where you maybe would not operate at all. For example, if it's a schwannoma or leiomyoma, which are, or sometimes you can even see a lymphoma. It's all rare, but it happens. And if it's a lymphoma, obviously you need to treat them with chemotherapy. And if it's one of the other two, then you don't even need an operation unless it's symptomatic. So that for us is a reason to do a biopsy.
And then for a carcinoid, you want to do a nodal dissection, which you wouldn't do for a GIST. So I think it does impact not only whether you do an operation or not, but the scope of the operation you do if you have to do an operation.
Yeah, so that's generally exactly why we do it. So in this patient, let's go back to the case. This patient, well, it was a GIST and it had upfront surgery, laparoscopically, and everything went well. So this is the first case. Let's go to the second.
right, I think I'm
Yeah.
controlling the screen here.
Yes.
There we go. So this is a patient of mine who had she was 65 years old, presented initially with hematemesis. She underwent an EGD, and the scope showed nothing in the stomach, but did show a submucosal mass eroding into the very proximal jejunum at the level of the ligament of Treitz. So again, question for this one, I'm going to show the image. Biopsy, yes or no? I guess we can, do we do the poll here again, Lena?
No, same question.
Same question.
Okay, just bear with me. So you'd like me to relaunch the same poll that we've just had as well, yeah?
Yes.
Okay, no. Let me just do the next one. Okay, there we go.
Okay. Need to make up your mind now.
Mm-hmm. Okay, I'm going to end the polling and share the results.
Interesting.
Yeah.
Yeah, so for this particular patient, we were able to actually get an endoscopic biopsy, but I think the small bowel cysts can be challenging to biopsy. And if the differential diagnosis is fairly limited, I think it is perfectly reasonable to consider going straight to surgery. But also, you're trying to rule out something like a retroperitoneal sarcoma, for instance, and so a transcutaneous biopsy may also be entertained. I think that it's a bit hard to make a decision based on just a single cut on the CT, but all of these are appropriately reasonable answers.
Yeah. In general, I think we always like to have a diagnosis beforehand, but sometimes it's not even possible, right? Because if you consider transcutaneous biopsy, I think in general, it's not a bad idea, but it's not that easy to reach this tumor if you look at the bowels that are, just on top of the tumor. So in this case, I'm not sure if it's feasible, technically feasible. If it will be close to the abdominal wall and it's not close to stomach, I would definitely do a transcutaneous biopsy just to make sure you know what you're treating.
And also with GIST, we worry that it may be at a slightly higher risk of rupture compared to some of the other soft tissue sarcomas. And therefore, we would try endoscopic if it's feasible.
Yeah.
All right, so we've got a biopsy that showed a GIST. So she underwent a small bowel resection. Pathology showed this was arising from the jejunum, 5.8 centimeters. Mitotic count was 3 out of 50 high power fields. So this was one of the first operations I did when I started my faculty position. Now I would potentially try to do this laparoscopically, but we did it open at the time. So now the question is, would you consider adjuvant therapy for this patient or just continue under surveillance? I think we have a poll question for that.
Yes.
Again, the 3 prognostic factors here: site is jejunum, size is 5.8 centimeters, and mitotic count is low, 3 out of 50. Yes. Okay. Interesting. Okay. Good. So we did give her adjuvant therapy, and I will show the next slide, which I think has the risk stratification. So based on her characteristics, jejunum, low mitotic count, 5.8 centimeters, her risk of recurrence is about 24%. That falls into the intermediate risk category. I think, so what do you think? Would you have given her adjuvant therapy?
So this is exactly the category where we find it hard to give adjuvant, because we generally said that if the risk is high, so let's basically say the red area, we give adjuvant. For 24, we usually don't, unless the mitotic count, no. In this case, we probably would not, no.
Yeah, so this is a controversial area. I think, what if the mitotic count were greater than 5? Say mitotic count was 6 instead of 3.
Then we would definitely give adjuvant, no doubt.
right, because that would put her into this risk category around 85% recurrence. So we did give her adjuvant therapy. We actually, because of the way the rules were written by the FDA here in the United States, there was no end point. And so she actually ended up staying on for 8 years, and then just got tired of it, stopped, and within about 2 years, she developed a recurrence. And so, and then that became quite a challenge to manage. But so I think it probably did delay recurrence in her case, but it didn't necessarily cure her, which is, I think, a point of debate with the adjuvant therapy studies.
Yeah, and I think we put this case in on purpose with the low mitotic rate, because the green area is easy because no one would do it around the world. The red area is also easy because most people around the world will do it. The yellow area is gray. No, the yellow is gray. That's strange. But the yellow area is controversial whether you should give it or not, and it depends per country. And also, I guess, shared decision. Yeah.
So does anyone have any, I guess, questions about this?
Yeah, there is one question from Pier Polo. He is asking about if there is an increased risk of peritoneal seeding by performing a transcutaneous biopsy. And the answer is we prefer endoscopic because they are fragile, and it's always been proposed that it might, if you do a transcutaneous biopsy, that you might see more intra-abdominal recurrences. So actually there are 2 studies, one from myself and London together, and from the Scandinavian group, that show that transcutaneous biopsies are in fact safe and doesn't lead to increased local recurrence rates. However, in both series, there was in total 1 case where there was a abdominal wall recurrence. So that's why we still say if you can do endoscopically, do it endoscopically, but otherwise you can do transcutaneous because the risk is very low.
And having said that, I've also seen our endoscopists for tumors that are very small or in a challenging location, they're within the wall where we can't necessarily see them very easily laparoscopically. They've tattooed the tumor site in a similar way to the way they would do the endoscopic finding and aspiration. And then you open up you get into the abdomen with the laparoscope, and you can see the black ink marks scattered on the peritoneum. So even though it's hypothetically safer, I've also seen cases where there's been ink staining. And so I don't think there's anything we can say is guaranteed safe. But I do agree that that endoscopic, if possible, is probably a little bit less risky than percutaneous.
But when you see a large tumor intra-abdominally, we really want to have a diagnosis because there's a large differential diagnosis. That's why we basically say do a biopsy because treatment really can depend on the diagnosis. Krunal, I haven't forgotten your question. I will come back to that later. Any more questions about adjuvant imatinib?
See, I think do I stop?
Yeah, I can go and I can share.
You want to do this one? Okay, I'll stop share. All right, why don't you take over there?
Okay. I just need to go. Okay, just quickly. Sorry about that. Okay, and then we are here. So we discussed basically the first part, and I've shown this slide before, all the stages of GIST progression, the small GISTs, the localized smaller GISTs, and then we are coming towards the right side of the blue arrow and then towards the green arrows. And we put the term reference center here because this is the area where we feel a referral really can have a benefit for the patient. Because it's not always that easy when the GISTs are larger, locally advanced, or even metastatic. So let's start with a case of a relatively large GIST. So this is a rectal GIST, a 68-year-old man that presented with constipation. And on rectal exam, there was a large palpable mass, which obviously is generally considered to be a rectal cancer. There was an MRI and it showed a 9.5 centimeter rectal mass, but on biopsy, well, comes as no surprise. In this webinar, it turned out to be a GIST. And as you can see here, it is a relatively large GIST. And if you would operate this upfront, it would definitely mean an APR for this patient for this large tumor. However, as we said before, these large tumors, and especially if we feel an operation might make the resection easier with a higher likelihood of clear margins and maybe even de-escalating this operation, we chose for neoadjuvant imatinib. So neoadjuvant imatinib was given. It was not in my center, by the way. It was in Jen's center. But anyway, neoadjuvant imatinib, 400 milligrams. And after 6 months of neoadjuvant treatment, the tumor has shrunk from this size to this size. So much smaller, a good response to imatinib. And in the end, they were able to do a transanal resection instead of an APR for this patient, which obviously is much less morbid. And the pathology turned out to be a primary rectal cyst with no mitotic activity, negative margins, and closest radial margins 1 millimeter. But as I said before, even 1 millimeter is enough for a cyst. So no mitotic activity doesn't necessarily mean that the mitotic rate wasn't higher at the beginning, but once you start treating with imatinib, the mitotic rate can definitely go down. So this doesn't necessarily reflect the biology of the tumor. So with this case in mind, these are basically the rationales for doing neoadjuvant imatinib. First of all, we feel we should consider it when there is definitely an indication for adjuvant imatinib. So these patients will have imatinib anyway, and if the indication is there, then in a way it doesn't really matter if you start with imatinib or start imatinib after your operation. So that's the first one. The second one is if there's an opportunity to de-escalate surgery, neoadjuvant imatinib might really be beneficial for patients. And I just put some examples here just to give you an idea of what this could mean for a patient. So for example, if you feel that you have a primary cyst that is of a certain size, let's say 10 or 12 centimeters, but it's located in a way that a subtotal gastrectomy is needed, or maybe even a total, or maybe even it's growing into pancreas. For these cysts, it really makes sense to treat them up front, because if it becomes smaller, you might be able to do a small wet resection of this tumor, meaning a much better function for the patient. Well, the same goes for the rectal cyst, and we've just seen an example. If you can downsize the tumor and make the operation easier, and maybe even transform it to a transanal resection, that's really beneficial as well. When it comes to the jejunal or the duodenal, sometimes you need a multi-organ resection, and obviously if you can downsize and just take a part of small bowel and nothing else, it's less morbid, less complications, etc. And also sometimes these tumors are large and they're probably resectable with only one organ, but still, if you can downsize them, extensively, then maybe you can prevent an open resection and do a laparoscopic resection, which makes sense as well. And the last thing, one rationale, is something that is a bit maybe controversial because there's no evidence. But what we as GIST surgeons always feel is that these tumors are, as we mentioned before, very fragile, very reddish, and almost like a mucosa of an organ. And they easily rupture. And after you've treated them with imatinib, they usually become more hyalinized, they become more grayish, more firm, I would say, and we feel they don't rupture as much and not as easily as a primary GIST without any treatment. So also especially for large GISTs, this might be an advantage as well. But again, it's not something we can prove, or it's not based on any hard evidence. So if you treat neoadjuvantly, when do you want to operate? Well, in general, we feel treat them at least 6 months, and you can go up to 12 months. And then depending on whether the tumor is progressive during imatinib, that's definitely a reason to stop imatinib and operate. When the tumor is stable and there's no benefit to be gained if you continue treatment, then operate after 6 months. And if there's still a response, and if further downsizing might lead to further de-escalation of your operation, then we continue surgery up to 12 months, depending on the response. So what about the evidence? Well, there's not that much, right? Because there have been the adjuvant trials, but in terms of neoadjuvant, there haven't been that many studies yet. So this is a small study that included locally advanced, but also some metastatic patients. And for the locally advanced but resectable GISTs, they included the patients that are mentioned here, and they started treating them neoadjuvantly with a relatively high dose of imatinib of 600 milligrams. And the responders, as in the protocol, went on to go for surgery. And the endpoints here were recurrence-free survival after start treatment, which means after starting imatinib, and they analyzed efficacy and safety as well. So this has been published in 2018. And from the 30 patients that were included, all of them went on to be operated, with most of them having a response. They concluded that it was relatively safe with low toxicity and without any discontinuation of treatment. They had 77 R0 resections, and again, these were all very large GISTs, and the operations were often organ preserving and function sparing, as they concluded in the discussion. Looking on the right side, looking at progression-free survival, the dotted line are the neoadjuvantly treated patients, and although it's very hard to compare them with the recurrent and metastatic patients, still after 3 years, the progression-free survival is relatively low, I think, for these locally advanced GIST with 70%. So one study has been started in Germany already a while ago, and we are still waiting for the results, and we hope that they will come, although we don't know for sure. This study aimed to include 40 locally advanced, potentially resectable GISTs. They treated them with a more normal dose of imatinib of 400 milligrams. The responders went on to have an operation. They intended not to do any post-operative imatinib, and their endpoints were radiological response and histological response, and also to analyze whether downsizing of the tumor really led to a difference in operation strategy, meaning whether it was more organ preserving and function sparing. Again, these are the studies that I feel we really need also in the future, because this will give us more answers to who do we want to give neoadjuvant treatment. And then to come back to the question before I go over to Chan, the response rate really depends on the mutation type, and that's something I think Chan will mention as well. But as I said in the beginning, 63% of the patients have a c-KIT mutation, and almost all KIT mutations respond really well to imatinib. Over 95% of patients with a KIT mutation do respond. So if we know the mutation type, we can predict response very, very well. And the same goes for the PDGFR receptor mutations. Some of them we know also respond well to imatinib, while others don't. So basically, you need the right mutation. And if you have the right mutation, the response rate is way over 95%. Chen. You are on mute, maybe?
Yes, okay. All right, so I think we've gotten most of the questions on the chat, and I think Dr. Fiore's question I have not answered, which sort of leads into this next topic, but it's a question about whether with neoadjuvant therapy, if you still have to do a fairly aggressive organ resection, can you just consider definitive medical therapy? And I think that the concern there, and the answer, I mean, yes, so you could. I think the concern would be that at some point the patient may develop drug resistance and start to progress. And so I think that ultimately, if it's localized disease, I would still consider surgery, regardless of the extent of resection, even if it wasn't able, even if I was not able to downsize the scope of the operation like I had originally intended. So then we get to the topic of surgery for metastatic GIST, and here the level of evidence is the lowest. We've talked about phase 3 trials for adjuvant therapy, phase 2 trials for neoadjuvant therapy, and here we really don't have any good randomized trial data. So just when it metastasizes, the two most common sites are liver and peritoneum. Local recurrences, that is true local recurrences at the primary site, are exceedingly rare for adult type GIST. And other sites such as lung or other soft tissue sites only occur usually late in the course of the disease. Nodal metastases for adult type GIST are exceedingly rare. The advent of the targeted therapy has clearly altered the treatment paradigm for metastatic GIST. Prior to imatinib, surgery was really the only option. because standard chemotherapy did not have much efficacy. But then with the advent of targeted therapy, it has sort of led to a reframing of the question of when do we consider surgery for advanced GIST. And three key observations were that patients can experience durable periods of a partial response or stable disease on imatinib, and I'll show you some of the survival curves next. Pathologic complete responses are rare in patients who undergo surgery for metastatic disease. So even if they have had a radiographic complete response or radiographic response, there can still be some viable cells. And then response to imatinib is not maintained indefinitely. So these are the first three agents that were approved for the management of metastatic GIST. Imatinib has a median time to progression or median progression-free survival of 24 months. Sunitinib, 6.8 months, and regorafenib, 4.8 months. And we'll keep those numbers in mind as we look at some of the data on surgery for metastatic GIST. So the question really is, does surgery add any benefit in terms of survival over staying on imatinib alone? Surgery doesn't replace imatinib, and patients who undergo surgery need to resume imatinib or whatever drug they are on at the time. But does surgery bring any additional benefit? And that was the initial focus of several phase 3 trials that were planned or started. One was started in China, which enrolled 41 of a planned 210 patients, but closed due to poor accrual. An EORTC study was started, which only enrolled 12 of a planned 350. And the study that we had planned in the United States did not even get started because the Chinese study and the EORTC study had such challenges with accrual. The Chinese data have been published on their 41 patients, and this was the trial schema here on the left. Basically, patients were randomized to undergo surgery plus imatinib. They were started on imatinib and then were randomized to undergo surgery and then resume imatinib or just continue on imatinib. The primary endpoint was progression-free survival. The secondary endpoint was overall survival. And you can see some of the characteristics of the patients. Here, most of them underwent a macroscopically complete resection. The primary endpoint was not actually reached. On all of these two survival curves for progression-free survival do seem to diverge. The p-value is only 0.09. There was some potential benefit with overall survival, but that was not the primary endpoint. Sorry. And so this doesn't definitively establish whether there's a true benefit to adjuvant therapy. It just was not a completed trial. But it does lend some argument to at least offering the patients surgery after they've been on imatinib for a period of time. This table summarizes some of the retrospective data that have been published. Most of these are single institution or a group of institutions. The largest study that was published was combining data from our institution and data from Memorial Sloan Kettering. But basically, these are all retrospective, and so there's always some degree of inherent bias in the patients that were selected for surgery compared to those that were not offered surgery. So that's hard to really compare the survival data for these patients to the survival data from the drug phase 3 trials. In our combined study with Memorial Sloan Kettering, we looked at a total of 323 patients undergoing 400 operations. And we categorized each patient based on their radiographic response to drug at the time of surgery, responsive disease, stable disease, unifocal progression, or multifocal progression. That means more generalized progression on drug. And this was amongst the group that underwent surgery on imatinib. We did have surgery on patients undergoing surgery on various different drugs, but this looks at just the imatinib group in particular. And what we found was that the median time to progression was 31 months for the patients who had responsive disease, 19 months for patients who had stable disease, 10 for those who had unifocal progression, and then those that had multifocal progression progressed rather quickly at 5 months. Overall survival, again, sort of broke out based on response to therapy. Again, these are all patients who underwent surgery and therefore had relatively reasonable volume disease. The important number, I think, is this one, the median time to progression of 10 months for the patients who had one side of progression, because the alternative for these folks would be to either get dose escalation of imatinib or to go on second-line sunitinib. And the second-line sunitinib, for patients who undergo sunitinib therapy, all comers, the median time to progression is less than 7 months. Now that includes patients who may not necessarily be good candidates for surgery, but it does give you some sense of what the potential median progression-free survival might be on the alternative line of therapy. And so we still do offer patients who have unifocal progression surgery because we think that we can try to keep them on imatinib for a longer period of time. Primary mutation was not an independent predictor of outcomes in these studies. One of the other reasons we actually consider patients for surgery is that once they start to progress, they can develop a number of different secondary mutations. And this was just a study that we did on one of our patients. I took out a total of 46 different tumors, and we did mutation analysis on each individual tumor. They all had the same primary exon 9 mutation, but they had 7 different secondary mutations. And that suggests that if you're going to go on a second-line therapy, it's going to be hard for a single drug to be able to target all of these different mutations. And therefore, I do try to consider surgery early in the course of their metastatic disease treatment. So to conclude, neoadjuvant imatinib is safe and may facilitate the ease of surgery. We don't know the ideal duration of therapy preoperatively, though we typically tend to plan for at least 6 months. And then the ideal candidates are those where we think that the surgical approach, either laparoscopy or the site of resection, esophagus, duodenum, or rectum, may be impacted. Tumor biology, as evidenced by radiographic response to TKI, impacts progression-free survival, particularly within the metastatic setting. And those that have responsive disease or stable disease on imatinib and who undergo metastectomy have a better prolonged progression-free and overall survival compared to those that are beginning to progress. Nonetheless, those that have progression at one site may also potentially benefit from surgery to try to stay on imatinib for a longer period of time. Those that are progressing at multiple sites probably are better off treated with drug rather than surgery. I guess you want to...
Yeah, maybe I will start sharing the screen here, and also to address, I think, a very good question from Pedro Martin, who is asking, do you recommend a new biopsy if progressive on TKI, on imatinib? It's an excellent question, because we tend to do it now and then, indeed, because sometimes the type of acquired mutation in these resistant patients might give you some guidance on whether you want to go on to second line or even do regorafenib first, which is a third line. Although this is all very experimental and not necessarily something that all people will do. Also, when there's progression and if it's oligometastatic, as Jen just said, usually if it's oligoprogressive, we tend to take it out. And then you also know your mutation, right? Because then you at least we will do mutation analysis. And then one more question that I think you addressed already, Chen, to Marco Fiore, but still interesting question. If a tumor is downsized, but not to the extent that you would have liked, would you do an operation? Well, we have a case where with an esophageal GIST, and actually the tumor was about 8 centimeters. We were able to downsize it to 1 centimeter, but this patient really refused her I can't pronounce that word in English, the resection of the esophagus. We held her on imatinib for about 3 or 4 years now, and it's still stable, right? And she didn't have her operation, which, you know, would be standard of care, but so far so good, I would say. Then let's go to the last cases. Here we have a patient, or maybe you can do this case, Chen, anyway, because...
Sure. Yes, so 61-year-old woman presented with abdominal pain, had a CT which showed an 18-centimeter mass looking like it's coming from the lateral wall of the stomach. She was treated initially, evaluated in New York, and she actually underwent a CT-guided biopsy out of the concern this might be a retroperitoneal sarcoma, but it turned out to be a KIT mutant GIST. She had an exon 11 mutation. So we have a poll question here.
Yes, Gemma.
Okay, I'm just about to launch. There we go.
What would you do? Neoadjuvant would you do surgery up front, or would you offer neoadjuvant imatinib followed by surgery based on the diagnosis of a KIT-positive GIST?
Okay, I'm going to end the polling.
Yep.
And share the results.
Good. So here, I think most people would favor doing neoadjuvant therapy in an effort to try to downstage this operation, in the sense that the amount of stomach that's involved is probably not going to change, but the ease of doing the operation will potentially change. You can do it laparoscopically instead of trying to take out an 18-centimeter tumor through an open procedure. Also, I think that the tumor can become more hyalinized, and that can make the ease of resection just a bit, or the resection a little bit easier and less likely to have the tumor rupture. Let's go on to the next.
Sorry. Yeah.
So we treated her for 6 months. Tumor shrank. You can see that there's quite a bit of low density material within the tumor along the lateral wall of the stomach. It still measured about 11 centimeters, but that was the longest dimension. So she underwent a laparoscopic partial gastrectomy. You can see sort of in the center of the screen, the hyalinized tumor. And yeah, right there. And so that was just much easier to manipulate. It ultimately measured 10 centimeters, and I was able to get that out with a negative margin. But the hyalinization just made it much more easy to manipulate and less likely to rupture. But we can let's take a twist on that case, and we can go to maybe the next slide. So here you have two patients with gastric GISTs. One has a KIT exon 11 mutation. The other has a PDGFR exon 18 D842V mutation, which is imatinib insensitive. So we treated the first, as I described, underwent laparoscopic resection and then went on adjuvant therapy afterwards. But the one below, he just went straight to the OR. And this is where the mutation analysis component comes into play, because the lower case would just not benefit at all from any neoadjuvant therapy. I think we have to end there because I think we're right at the time.
It's no problem, Dan. It's no problem if you want to carry on for a little while longer. It's up to you. It's no problem.
No, we have one more. Yeah, we have one more case. So I think it's a metastatic case that we can do. It's the last case, and then we have room for some questions if there are any. So this was a metastatic patient that was referred to us with, as you can see on the CT scan on the right side, it had an abdominal metastasis of a GIST and a large liver met that you can see there, and one smaller liver met that was close to the large one. These lesions were much smaller when they arrived, but this was an N-of-1 GIST, meaning not a sensitive GIST for imatinib, or not really sensitive to sunitinib or regorafenib. So this patient ended up in a study where it received cabozantinib, another tyrosine kinase inhibitor, and this patient had it for 1 year, and it remained stable for a while. But at that moment, especially the liver met was growing, although it might be pseudoprogression because there was a lot of maybe hemorrhage there as well, but still progressive, and also the abdominal lesion was a bit progressive. So at this point, we had a progressive patient under cabozantinib, and basically we had two options: go to second-line treatment, although these treatments are most likely not very effective in an N-of-1 mutated GIST, or do a large operation, hemihepatectomy, with a resection of the abdominal lesion, which was on basically fourth part jejunum, fourth part of duodenum, beginning of jejunum, so a major operation. So what would you do? Please, the poll, Gemma. So these patients are really always discussed extensively in our MDT, the multidisciplinary team. And I think the message of today is also that, especially for more difficult GISTs, you really need an experienced team with all disciplines, right? So your pathologists and your radiologists, but definitely your medical oncologists and your surgeons. And these cases, you know, there are always different options. There's I think never a right and wrong, definitely, but at least you need to consider your options and make a good choice of what you would do. So Interesting. 27% would proceed to second-line systemic therapy. Well, it's defendable, definitely. But yeah, mostly surgeons in the room, I guess. So 73% would do an operation, and that's what we chose as well. So we went on to do an operation. So in one session, so we did a hemihepatectomy and resected the tumor. And the patient is doing well so far. It's been a year now, and so no adjuvant treatment because there's no KIT mutation, but still doing well without any signs of metastases. Although I think at the end it will come at some point, but still disease-free now. So just think about this. There's no poll about this, but what if this was a KIT exon 11 GIST on imatinib? So it's a sensitive tumor that supposedly would have had this patient on imatinib for a year or 2 years and then become progressive. Would you do the same? Second line sunitinib, which is less efficient than imatinib, or would you still go to surgery? And I think this is a very difficult question. Jem, what would you do?
I would have done surgery. I think that the NF so if it were a KIT mutant GIST or NF1, are we still talking about the KIT mutant scenario or the NF1 scenario?
Sorry?
Are you talking about it in the sense?
No, yeah, well, both actually, but yeah.
So I was just responding to Dr. Fiore's reply or question here, but I think that if it's a NF1, I would have definitely done surgery because like as you mentioned, the subsequent treatment options are rather poor. With KIT exon 11, I might have considered sunitinib, but again, the data just are not strong to come down very hard on one option versus the other. We tended to be pretty aggressive, and if it was just the liver lesion that was growing, I might go for surgery. But then if there's that peritoneal disease that's also growing, then I might not go for surgery. But if it's just one side, I most likely would recommend surgery.
Yeah, I think I agree. Yeah, 2 lesions, second line, 1 lesion, operation. Yeah. Well, I think that's it for today. We have no more slides. I don't know if there are any more questions from the audience. Time to ask.
Or if anyone, I guess, wants to, can we offer them, ask them to unmute if they want and ask a question?
Yep. Of course, yeah. Please do so. Obviously, if they feel comfortable to do so. Otherwise, I think I can see a couple more in the chat area as well.
Right. So from
a question from Emmanuel Zapatini. Is there any tumor biomarker to follow after resection and even after local recurrence? Well, excellent question, but the answer is fairly easy. There is not. Basically, we don't have a good blood-bound biomarker or anything else, which is too bad, right? Because we need the imaging. And there is another question, which is the role for endoscopic resection in gastric GIST. Also a good question. So I think this field is evolving, especially for smaller GISTs, obviously. So my gastroenterologists tell me that they can do up to, depending on who you talk to, 2 to 5 centimeters. I think 2 centimeters, yes, you can definitely do, although we also mentioned that there's no clear indication to do those. But I think the ones that are becoming a bit larger, some of them might be resected endoscopically, I think. But then again, there are GISTs, especially gastric GISTs, they are basically exophytic growing tumors and endophytic, so meaning inside the lumen or intraluminal or outside. So obviously the extraluminal are probably much harder to resect endoscopically, but the intraluminal, I think in the future we will see more of those, also in the rectum, if they are up to, I don't know, 3-4 centimeters. Let's see.
Yeah, I think it's and that's where sometimes you can do that yourself. So I've used and I've had situations where you've actually used the endoscope as your camera, but then put the ports in laparoscopically directly into the stomach for an intraluminal tumor, and then you just staple it off, put it in the bag, and bring it out to the stomach wall, but you minimize the number of ports you need because you use your endoscope as a port, essentially. Or if they're really complicated, you can do them together with a gastroenterologist, and we've done that as well. I think the rectal ones, again, whether you do them yourself or some of the more complicated ones are done with our colorectal surgeons. But it really you want to get a negative margin if you can, but you shouldn't necessarily have to do such a wide excision that's going to cause functional problems. And so it's being judicious about the extent of resection and what the morbidity of the operation is.
I see 2 more questions. Would it be feasible to use liquid biopsy to see minimum measurable disease? Well, it's the same answer as before. At the moment, there is no clear biomarker, especially not a blood-bound biomarker. I mean, sure, there are some suggestions that maybe you can use circulating DNA to look for the c-KIT mutation, but so far, these things are theoretically maybe feasible, but so far it hasn't been developed or even validated in clinic. But who knows, in the future, these are things that we are going to see. And question 6, liver mets, easy operation. I'm not completely sure what you mean, David, but usually if a patient has 6 liver mets, I would not easily go to resection for GIST. You, Chen?
Thomas had a question about metastatic GIST exon 11. Consider a metastectomy after primary oligometastatic disease after a good response. Yes, I think it's assuming that there's everything is stable or responsive on imatinib. Yes, I think that would be appropriate to consider.
Yeah, completely agree. And sometimes it works out well because I think we had a case like a couple of months ago where we did this, and then everything works well. But then we also had a case. No, this case was like 2 years ago, and I followed the patient, and it's still completely stable under imatinib. But then we also did a case not too long ago, oligoprogressive, and then the first follow-up scan, it was full of metastases intra-abdominally. So in that case, it was just, let's say, the first lesion that was resistant, and then it was many to follow. So you never know, right, in advance whether it's a good option or not. But I think it also depends on the extension of the resection. If it's a major resection, I will be a little bit more reluctant than when it's an easy laparoscopic resection.
Correct.
Okay.
So if we haven't gotten your questions, you have our emails right there. So feel free to send us a message.
Yes, great. Thank you. You beat me to it, Jens. Thank you very much. I'm sure it looks like everyone's had plenty of questions, but as you said, it's after these things, you always think of another question to ask. So knowing that they can contact